Good afternoon, ladies and gentlemen, and welcome to this afternoon CME. Our speaker today is Dr. Castro. Dr. Castro received his medical education from the Mosque, did I get it right? Medical College in Columbia. He completed his residency in internal medicine at the Medical College of Wisconsin in Milwaukee, and a fellowship in infectious disease at the Creighton University in Omaha, Nebraska. Dr. Castro is board certified in internal medicine and infectious diseases. He cares for adults with multitude of infectious conditions, including but not limited to skin infections, endocarditis, osteomyelitis, prosthetic joint infections, HIV, and atypical microbacterial infection. Help me in welcoming Dr. Castro.
Thank you. Anybody hear me okay? Yeah. All right. All righty. Some materials, so I'm going to try to go as smooth as possible. I don't have any conflict of interest from a financial standpoint. This is just for my pleasure and your pleasure. And the three big things that I want to cover today is try to discuss the most common tick-borne illnesses in Wisconsin, which are anaplasmosis, Lyme disease, and babesiosis. That doesn't mean by any means that are the only tick-borne illnesses that might happen in this area, and things might change in the future, but I think this is the minimum that needs to be kept in mind for a provider in this state. Some other things that can be seen more often will include things like ehrlichiosis, Powassan virus infection, and some of the spotted fever rickettsiosis. The most common one will be Rocky Mountain spotted fever, which by the majority of the cases are people who go to places where RMSF is endemic and they come back. By the time they come back is when they develop some of the symptoms. Something to keep in mind, and that's an important concept in tick-borne illnesses and infectious diseases in general. Trial history is important. So again, a lot of different tick-borne illnesses. This is a subject that, to be honest, can be daunting at times. Many different vectors, different geographical situations to consider, many different animals that can be transmitted by tick-borne illnesses, bacteria, viruses, parasites. So it's not the most pleasant thing, I guess, to know you compare with something very simple, influenza, for example. So it's a source sometimes of frustration. So again, a sample of some of the things that might be more common to be seen in this area, and some other things on the right side. Again, this is definitely not a comprehensive list at all, where you can have infections like Borrelia mayoni, things that are relatively new organisms, recently described, like Harlan virus, for example, that is a relatively new entity as well, and some other things that they don't even have a name yet. So that gives you an idea how the field moves in this area. So many different ticks, but for clinical purposes, the three big ones to need to consider will be Ixodes, Scapularis, Ixodes pacificus on the west coast, the Lone Star tick, a little bit south, and the dog tick, which for the purposes of Wisconsin might not be that important, as you will see in a moment. And as you can see, size-wise, that's why it's hard for them to recall that they're having a tick bite in the first place, especially that the majority of infections happen when they are very tiny. So the fact that they tell you that they don't remember having a tick bite doesn't really mean that much. They can still have it. And as I said, there are some geographical distributions, and that is helpful to determine what kinds of tick-borne illnesses you need to think about. And again, in our area, by far, the most common one will be, again, Ixodes, and its cousin, Ixodes pacificus on the west coast, and Amblyoma, again, towards the south. But again, this is obviously not written in stone. This is not a wall right here. So it's possible that at some point there will be maybe some overlaps, some changes, impact of weather, contact with other animals, invasion of humans in other environments. So this might change as well. So things to keep in mind. And because of that, because of the distribution of the vector and distribution of some of the intermediate hosts, then there are some areas where these diseases are more common than in others. And again, in our particular situation, Lyme disease, Babesia, and Anaplasma will be by far some of the most common ones. But as you can see, ehrlichiosis, for example, a little bit more common than it was before. Not necessarily in this part of Wisconsin, but nonetheless, it has been described, probably more toward the west part of the state. I used to work in Missouri, and by far anybody with fever in summer got doxycycline before asking any other questions, I guess, to give you an idea. So again, distribution, very important. And as you can imagine, most of this thing happens when ticks are more agile and mobile. So summer and fall will be some of the places to consider tick-borne illnesses. And some of them might take a little bit longer to present. Incubation times are a little bit different. But again, this is mostly a thing that doesn't happen in winter, generally speaking. And unfortunately, not only can be things that can be transmitted by ticks, as we can see in this example, but some other things to think about that might present with very similar symptoms, the fever, the malaise. Some of them might come with a rash, some might come with transaminitis, some of them might come with arthralgias. So there is a lot of overlap, and that's what I think makes it sometimes so difficult to diagnose. So some things might help you to differentiate from a clinical standpoint, but this is definitely not a rule. It's just some orientation to help you guide where to think about. So, but again, just from a clinical standpoint, doing a diagnosis of a tick-borne illness is a difficult thing. So we're going to start with the first one, which is anaplasmosis, which is caused by Anaplasma phagocytophilum. It has previously called or HCA, which basically gives you an indication that the cell that is affected in this situation is a granulocyte. It's an intracellular organism, so that's why it forms these little berry things inside that we call mole, which is one of the hallmarks of the presentation of this infection. And again, it's a somewhat recently described entity, and we consider anaplasmosis an emerging infection because there has been progressive increase in the number of cases. And again, by far the most common one for transmission will be a tick bite, but also there have been some reports of transmission by contaminated solid organ transmit. And this will be the area to think about anaplasmosis, and again, a reflection of the vector, again, which will be Ixodes scapularis in this particular situation. And as we were talking before, we have seen some increase in the number of anaplasmosis cases throughout the years. Most of the cases seem to happen in older people, but I think part of this is because that's probably a population that is going to get more likely to have symptoms from this infection. Most people won't feel much of a thing. More people actually have an asymptomatic infection. But the older you get, the higher chances that you're going to seek a medical attention, more chances to be tested for anaplasmosis if you think about it. And as I said again, summer, fall, this is where you're going to see many of your cases. So again, very non-specific most of the time on the presentation, the fever, the headaches, feeling like a bad cold sometimes, some muscle pains, nausea, some abdominal pain, which might be something to think about compared with other tick-borne illnesses. The gastrointestinal component tends to be a little bit more common in anaplasmosis. Sometimes it can present with cough and confusion, so it can be a little bit atypical in that situation. Rash in general is a rare condition for anaplasmosis, so you see something that looks like anaplasmosis, but you're also seeing some issues with a rash in there. Then it's important to think about a co-infection because the Ixodes, the tick, can carry different organisms at the same time during the transmission. So again, in this area, by far, Lyme disease will be much more common, but again, somebody traveling from other places might be coming back to Wisconsin with Rocky Mountain spotted fever. And again, most of the time, it doesn't really happen that much with this. It will go away. Many patients will not even seek any medical attention, but some people with certain particular situations might develop serious disease. Again, people who might have a higher chance of not being able to deal with infection. And by far, the most common one will be a person with any sort of immunosuppressions. One of the most common things we see is people who are receiving tumor necrosis factor alpha inhibitors. But some other kind of insulin suppression, HIV, some other things out there can make people really sick, and again, it might manifest with some other more delicate things like acute renal failure, neurological problems, and ARDS, which might be some of the manifestation why people might present with cough and shortness of breath. The mortality in general, especially when it gets treated, is not very high. So this is the kind of thing that you want to think early and treat early as fast as you can. So you have some clinical diagnosis. You can prove that by performing some testing. The recommendation will be to do a PCR testing, which is trying to measure genetic material of anaplasma. There are some panels that will measure not only anaplasma, but some other similar bacteria like ehrlichiosis, which are basically cousins. And if you can also, you can do a peripheral blood smear to try to see whether the neutrophils have these modula, these inclusions, to give you some clues about it. You can also request titers, so you can do an immunofluorescence antibody to measure both IgG and IgM responses, IgM being the early response, but again, this is not going to be positive or showing up in a person with early presentation. So if somebody has a negative test and is just showing up with some disease, don't dismiss that this cannot be anaplasmosis. If you have any doubt that the test is negative, then it will be better to treat empirically before you get the results. And even in many cases with early disease, the titers will come back negative, so that doesn't again rule out the disease. So again, never delay the treatment pending laboratory results, and never hold because you have a negative test, especially in early disease. And the treatment, very easy, is doxycycline 100 twice a day. Time for when to treat, you can treat it up to 3 days, maybe more depending on the clinical situation. But 3 days in a person that is not that symptomatic should be more than enough. In pregnancy, rifampin will be the medication of choice. Maybe the concern will be maybe relapses, because doxycycline has a better track record. And again, usually the medication works extremely well. So if you don't see that the patients are really responding that way with doxycycline, a miracle drug, then maybe you need to think about an alternative diagnosis. So the second one, which is the biggie, I guess, because there are many things going on, many different presentations, will be Lyme disease, again, transmitted by orophrenic solis. It's a spirochete, so it's a different kind of bacterial species, and again, tick bites by far most common cause of presentation. Things that you see on the internet about transmission by mosquitoes and some other things, nothing. Just this is a tick, and this is a tick that is just waiting to get into your groin or your calf. I think the term is called questing, that they got like this, waiting for grab to you, and they don't jump. But they can detect carbon dioxide, so they can detect whether you're around or not to do the thing. And again, this is the kind of thing that happens mostly in summer, fall time. Very interesting cycle that involves humans as hosts that shouldn't be there, but there are some other things involved, including the white-foot mouse, white-tailed deers, and by far the most common transmission will happen with nymphs, the very tiny ones, but adults also, especially the females, which are the ones that have kind of halfway that shield here. And you can see that the rest of the stuff is the stuff that is going to engorge with food. As you can see on the right side is the ones that can transmit infection. You can see this one also put in some nice eggs for the next generation right now. And the distribution by far very common on Northeast, and that's why the name Lyme disease comes from. Seen in Connecticut, but it's also a disease that has been seen in other places like the Midwest, and as you can see in these different maps, there have been some increase in the areas where Lyme disease has been reported. The fact that you see some other points in different places out of the Midwest and the Northeast part of the country is more likely related to the fact that, again, you can go to places where you can get infected and they do the diagnosis in other places. So by far, this is an area that you need to think about. And it's possible that there might be some increases in the future where these infection might be more prevalent in states that we don't think are that much prevalent nowadays. And we think also that there have been some increase in the reporting. After this year, there was a change on the definition for Lyme disease, so that's why you can see whether it's a very solid case or maybe a probable case, and the graph make that particular distinction. But overall, there has been some increases in the number of Lyme disease reporting. So something to keep in mind. Most of the time it happens in people who are out there, takes the chance to become your next meal. So again, kids, younger adults, those will be the big groups. Again, kind of interesting to see that they differentiate between male and female, I guess. So maybe the kids, I guess, my kids might be more adventurous, I don't know about that. But in any case, kids, younger adults, people that are out there doing stuff are the ones that are going to get the tick. And again, by far, summer, fall, those will be the big times where this can happen. And again, thinking about the incubation period, takes about 20 to 30 days. So very uncommon to see any particular diagnosis out of those time frames. And by far, the most common presentation will be the presence of the rash, the erythema migrans. But even in the acute presentation, they can present with other things, including arthritis, palsy, neuropathy, meningitis, and cardiac involvement. But I guess the question is whether maybe the person is just showing up after the disease has been there, lingering and causing some of the late effects. That's what we are afraid of when we see Lyme disease. So again, the initial presentation, again, in the first 30 days tend to be, again, very non-specific. The fevers, the malaise, the headaches, some muscle joint aches, maybe some lymphadenopathy, and the erythema migrans rash, that you can see the classic target bullseye lesion, but it's not necessarily the only way this rash is going to present. Sometimes it can be flat, sometimes it might look more like a mosquito bite with a central acro orientation. So some particular example, again, this is definitely like a board question right there. But this is a little bit more subtle. Again, you can kind of see the differentiation between normal and normal skin, very well defined with the central spot right there, which is probably where the tick was located. And then this is where we get worried. So, most of those things might resolve, but then if you don't get treated, is when you start getting these complications, including the arthritis, which tends to be a passive polyarticular arthritis, usually large joints, very small number, the neurological stuff, and facial palsy, by far one of the things that you really need to think about Lyme disease in this area. Neck stiffness, encephalitis, encephalomyelitis, nerve pain, memory issues, or issues with involvement of the cardiac conduction system. And it can cause, again, obviously palpitation, shortness of breath, which will be a condition for Lyme carditis. And some people might have these recurrent rashes. It may look similar to the initial rash. It could present most of the times in the site where the original rash was located. But some people might also develop somewhat similar rashes to erythema migrans and located in different places as well. So something to think about, these rashes that might come back and forth, something to think about for Lyme disease as well. And an example of Bell's palsy, and this is kind of an interesting example, which thank God we don't do in clinical practice that often. So this is cardiac tissue actually, and you can see the spirochetes right in there. So testing is probably one of the most confusing parts from Lyme disease. First, because it's difficult to understand exactly what is the recommended sequence, and there are providers out there that jumps out and they start doing testing from this part. And not only that, but there are some laboratories that are designing this particular test that are not necessarily approved by the FDA or necessarily validated in a scientific manner. So you're going to see a lot of things out there, especially if you spend some time Googling stuff that are not necessarily real. So we know that the test is not perfect, but no test is perfect. And a test is very useful when you really know how to use it. Other than that, any test is not that great. So a test might be negative in early presentation, so that's one big thing that you need to think about, that those antibodies take some time for them to develop. So again, somebody that comes with erythema migrans, you do this test and it's also negative, then don't feel that, if you feel that there's like Lyme disease, it's likely to be Lyme disease, even though there is not enough time to form those antibodies. But this is what is recommended. So you have this two-step approach where you start with an antibody-based testing either by enzyme immunoassay or immunofluorescence. and then the laboratory will tell you what is negative, then this is what you have. Again, if it's less than 30 days, that's the person that maybe you want to repeat it if they're not having necessarily a very clear picture. But generally speaking, a negative test is a negative test. The laboratory otherwise will tell you, well, it's kind of positive or equivocal result, and then they will do a reflex test with the same sample, and they will try to do a Western blot, which is a different method of measuring this. And Western blot, like you remember from maybe your biology classes, is to try to detect the actual proteins that are part of the actual bacterium, and they get run in this nice tophoresis paper where they get graded by molecular size. And this is where these KDA things come, which are kilodaltons. So they get tested for whether they have bands that detect either an early response or a late response. And this is what the laboratory will be measuring. And again, these are kind of the names of the proteins for reference on this side. And then on the run side, you'll see some of those bands. And that's where the bands that you'll see reported on the lab report come from. And based on the studies, they have this criteria to decide whether a band is considered a positive test. It's not just one band, but it's a combination of a certain number of bands. And again, those are different proteins that are present on the Borrelia burgdorferi. So again, like any other test, there are some false positive testing. It could be related to maybe the presence of other treponema animals out there, like Borrelia recurrentis, which will be the cause of relapsing fever, or leptospirosis, which is caused by leptospira as well. Treponema denticola, very similar to Treponema pallidum, causing syphilis in itself, another treponema animal. And some other things that might cause this cause-of reaction, like anaplasmosis, autoimmune disorder, especially lupus, bacterial endocarditis, which you can imagine, unfortunately, can generate a lot of immunocomplexes, so I think is part of the problem. And some other infection, a little bit more prosaic, like H. pylori and Epstein-Barr virus infection. So something to think about. Again, the important part is to understand the limitations of the test and how to use it the most appropriate time. But it's a pretty easy test. Treatment, and I don't know if we're going to have any handouts or not, so I'm not going to go through all this stuff. And to be honest, the majority of you guys understand the treatments are very easy to understand. It's either doxycycline or amoxicillin or cephalosporin or ceftriaxone if you need IV treatment. So that's relatively safe. And the majority of the presentations can be treated with oral presentation. And to be honest, I think in this country, probably we jump a lot in using IV ceftriaxone many times. Many places in Europe will actually use doxycycline even in cases of neurological presentations, though. But that's not necessarily something that a lot of providers will feel comfortable treating in the first place. And in most of those cases might not necessarily work, so you might end up doing a second trial of treatment with ceftriaxone. So you say, well, why am I wasting 4 weeks of treatment? But in general, we reserve the use of ceftriaxone for things that are a little bit more complicated, like again, neurological disease, cardiac disease, and arthritis. And the majority of the time, we treat between 2 to 4 weeks. The medication is relatively well tolerated in most of the times. And again, most of the time that you see, for example, in cardiac disease, where you might see maybe some blocks or things like that, most of them are very innocent heart blocks, and most of them will resolve without any need of a pacemaker or things like that, as long as you do your diagnosis. So maybe this is probably the part that I think as just an infectious disease provider kind of dread the most when you have a consultation for Lyme disease. Especially when people have this concept of chronic Lyme disease, which I think it's a misnomer. We know that some people that get treated for Lyme disease, that they get treated adequately for, depending on the clinical situation, might not necessarily have complete resolution, or they might end up with some very non-specific symptoms even after treatment, maybe some fatigue, malaise, some arthralgia, some other things. So if you go up there, and again, you spend maybe too much time doing some Googling, the question is whether you really need to be on more antibiotics that we usually recommend. And that's where this particular parallel universe of treatment kind of start ensuing, whether you have patients who are in antibiotic therapy for months and they need to be on a PICC line for months, where it's just, it's not real. So most of the time, we actually think that if a person happens to develop symptoms again after treatment, we think it's actually more likely to be a reinfection, not necessarily a reactivation. We don't have really scientific evidence to say that there are some lingering places in your body where maybe the antibiotic doesn't reach enough and it kills the bacteria, and maybe you have some dormant places. That is not right. So again, you can put patients on antibiotics, but what you're getting from that is just the side effects. You're not really doing anything for them. And this question has been answered multiple times. So this is not just my opinion. There have been some placebo-controlled trials to prove whether keeping patients on prolonged antibiotic therapy have any different symptoms-wise in people who do not receive prolonged treatment. And again, that has never really been proven, though, that there is any difference on symptoms or any difference after the antibiotics. And again, most of the times that you can measure placebo effect, it can be a substantial number. When you hear these anecdotes of people, oh, I'm feeling better after 2-3 weeks, 2 months, why are you not doing this? Why are you such a bad doctor? These kinds of things is the kind of information that need to be discussed with patients. And they need to understand that there are some limitations, and there is definitely a lot of research in all this, but so far we do not have evidence that prolonged antibiotic makes a difference. And actually what you're getting is the short end of antibiotics. And there's a lot of documentation about particular side effects, including anemias related to ceftriaxone, all the gamut of biliary tract disease that can happen with ceftriaxone, starting from the classic biliary sludge that can form with ceftriaxone, cholelithiasis, cholecystitis, C. diff infection, including death from Clostridium difficile infection, drug reaction with systemic syndrome and eosinophilia, line infections, bacteremia, osteomyelitis, septic arthritis, septic shock, death. Those are all complications for prolonged IV antibiotic therapy that is not necessary. And obviously, many patients will end up paying out of pocket for these kinds of treatments. So there's no way to gain anything from this. So the third one I wanted to cover will be babesiosis, so a little bit different animal, which is actually a parasite, somewhat similar to malaria in some aspects. The most common one we have in this area will be Babesia microtia, which is kind of a misnomer as well, because based on some genetic studies, we think that it's probably a clade of bacteria, and there might be 5 different species, but it is confusing enough, so we're just going to leave it at microtia for now, I guess. But some other similar organisms in other places in the country, in other places in the world, can develop the clinical picture that we call babesiosis. And again, some of them they don't even have a name. That gives you an idea that this happened in Missouri, probably around Cape Girardeau or something like that. And that's kind of, again, the challenges of these tick-borne illnesses, many different things being discovered day and day. Again, the transmission by far a tick bite, but blood transfusion, especially packed red blood cells, will be the big one. And there's not really a good test to test for on blood products. And I'll give you a quick story about that. The Blood Center of Wisconsin has been trying to validate a Babesia testing on their products, and it's not a great test yet. And what they're doing is that they're sending these letters to the patients who donate blood, and they say, well, you might have babesiosis, we don't know about it, go talk to your doctor about it. So those have been interesting conversations at the hospitals. I call them and say, so what gives? So what should I do? So there's some things, I mean, you can tell the laboratory and they will do some Babesia microbial titers, but who knows what that means, though, and it's tremendously frustrating for people as well. So congenital might be also a particular way of transmission, not that common. And obviously it's a notifiable disease for national purposes. And the name of Babesia comes from this folk, which is old bacteriologist from, it was from Romania, I believe. So just some historical tidbit right there, I guess. As usual with parasites, the life cycles tend to be very convoluted, complicated, and again, somewhat similar to what you see with malaria, where they have sexual forms and accentuated forms. But basically, in the end, those things have sex on you, and they end up going to your red blood cells. And the problem that causes, and the red blood cells causing this hemolysis, is where most of the symptoms happen from having babesiosis. And again, most of the time transmitted by the tiny little things that you see right there and give you some idea of the size. And most of the times it will not necessarily cause a lot of disease. If you are healthy, you don't have any major problems, maybe some fever, some malaise, and that's about it, but we might see some other things. And again, in general, it's very similar to where you can find ixodes. And again, you have ixodes pacificus, very similar, so you can see some cases in other places, but again, Midwest and especially Massachusetts, that area is Babesia County. So some cases in Wisconsin, to give you an idea about the numbers, so very, steady against maybe the climate. I don't think there's much to see in that graphic, but that's kind of the number that have been reported for the state and somewhat recently. Yes. So again, most of the time you're not going to see that you have babesiosis. Most of the times it will be maybe like the flu, fevers, chills, headaches, malaise, anorexia. Again, very similar to anything, right? And again, if you have a rash with this, then very unlikely that this is just babesiosis. You might have other things, and again, in this part of the country, Lyme disease will be the first thing to think about. People who have problems, older people, I have no spleen, my HIV is on control, I have cancer and it's been on treatment, I have immunosuppression for XYZ reason. That's the people who might get in really bad situations with babesia. What kind of things? Well, again, the red blood cell is the place where it's going to end up being attacked, it's going to be destroyed. So hemolytic anemias are by far the most common ones. So you can see the anemia, low hematocrit, elevated LDH, those kinds of things. And also it can affect other cell lines, including the platelets. You may end up with thrombocytopenia, maybe some transaminitis, or maybe a little bit similar to what you see maybe in anaplasmosis. And if you see also problems with your neutrophils, then that's when you have to think that maybe you're dealing with a cold infection. So anaplasmosis in this area will be the big one. How do you do the diagnosis? So by far gene sustain, and you can see some inclusion signs there, out there, very classic for babesia. You're gonna see this 1, 2, 3, 4, this tetrad right there. Some people call it the Maltese cross, very, very common for babesiosis. And actually, we had kind of a case of that earlier this year, and actually when it was from a person outside the country, and everybody was freaking out that it was malaria though. And actually, just by talking to the patient, you easily realize that malaria was not a risk even with her trip overseas though. But then when we saw the slide, then that was what gave the diagnosis. So it was a case of babesiosis. So she got sick here, not in Thailand, I believe that's what she did. So you can also do some immunofluorescent antibodies, but again, like all antibody testing is going to be a while before you get some positive results. So the fact is negative doesn't necessarily mean that you have ruled it out. There are some PCR-based testing that you can do to detect DNA pieces of this animal, but again, genes are very cheap. If you had a good technician up there in your laboratory, very easy enough to diagnose. So again, by far, it's a very mild illness. Many people won't even consult their provider, and things will go away, it will be cleared. But if you happen to have somebody who have maybe some mild symptoms, you have some combinations of treatment, you can do a topical and azithromycin, very, very well tolerated in general. And again, that gives you an idea how similar this is to malaria. This is actually a medication we use for malaria as well. In more serious cases, then the situation is whether you need to use some other things, some other kinds of medications like clindamycin and quinine, and again, very similar to what we used to do with, or what we do sometimes with malaria. That's the kind of medication that you need to put patients on in the hospital, put them on telemetry because of QTC prolongations and things like that. And that's the kind of thing that you want to have somebody that knows what they're doing to help you guide, because this is a serious condition. You might end up requiring exchange transfusion, especially if you have hyperparasitemia, anemia, or you have maybe some in-organ dysfunction. And some people might have recurrence or persistent parasitemia. So that's the people that you have to keep doing some peripheral blood smears, try to quantify that the parasitemia is getting better. you don't necessarily need to treat until the paracytemia is completely gone, but if the patient are asymptomatic and paracytemia is less than 2-3%, I believe, then you probably are off the hook on that one. But some people, again, might need to be retreated. So that's the person that you want to see in follow-up after the diagnosis and after the treatment. Okay, so I guess this is the gimmick part of the presentation. I hope not. So for the people who know me, I'm a little bit techy, maybe too much for my own sake. But I thought that maybe we can do some cases and you can help me out answering some questions here. So this is the first case. 22-year-old man in emergency room, 1 day history of fever and headache. 1 week ago, presented to the internist with a skin eruption in his abdomen, which was diagnosed as erythema migrans. He received amoxicillin for 14 days. The skin eruption result, examination, maybe mild fever, blood pressure seems okay, a little bit tachycardic, respiratory rate 22, maybe a little bit high. Patient is ill appearing, no skin lesions are noted. The laboratory test down there, you can see some hematocrit level, pretty decent right there. The leukocyte count, maybe a little bit on the low side, same for the platelet count, and some thrombocytopenia. A little bit of transaminitis, not too bad. The total bilirubin pretty good, so not necessarily a cholestatic pattern. And the lactate dehydrogenase, not too bad either. All right, so this is where the gimmicky part of the presentation comes. All right, so you can do it over the phone. I think you just need to do it once if you want to use your browser on your cell phone, or texting. Okay, so you're going to answer me whether this could be a case of babesiosis, Owassan virus, which we didn't talk, but again, very similar presentation. Relapsed Lyme disease, the guy just had maybe a rash suggested for erythema migrans, or anaplasmosis. So again, think about it. Maybe babesia, Owassan virus, Lyme disease, maybe coming back again, nobody knows, or anaplasmosis. Any takers? I don't have any gift cards, so this is just for educational purposes. Anybody having problems connecting? Anybody brave enough? Okay. Again, you're not going to be punished. You're not going to see your Christmas bonus being taken away. Okay. Somebody brave out there? Okay. Anybody else? Okay. Okay. Well, that's tight. Okay. Right? Okay. All right. Okay. All right. Okay. Anybody? Tiebreaker? Ooh. Okay. All right. Let's see how many brave souls we have. 5 brave souls. Anybody else? Okay. Actually, the correct answer is anaplasmosis. Though. Again, this person received the treatment, probably had Lyme disease, it's possible. They didn't really go away with the treatment, right? And again, having maybe some transaminitis, some bone marrow compromise as well, right? So anaplasmosis is. All right, so don't close your browsers, we'll go to the second. Okay, 47-year-old man, skin lesion. 2 weeks ago, his wife noted an erythematous macule on his back. For the ensuing week, the site became progressively larger. He notes mild fatigue, but no fevers. He recently returned from a vacation in Sheboygan, which included outdoor activities, like riding, walking to the beach. He reported no known tick attachments. Physical examination, low grade temperature elevation, pressure, they're okay. Pulse rate 52, respiratory rate seems to be pretty decent. Okay. So for the ones using the browser on your phones, I think they should be refreshing automatically. If not, let me know. So what should we do about this person? Okay? And somebody said, just doxycycline, that's the magic drug. Okay. Okay, well, maybe it's Lyme disease, okay? All right. All right. Not doxycycline, all right. Doxycycline is cheap, so far. Okay. Anybody else? Okay, 110, that's nice. All right. Okay, I think we're seeing a leader here. Okay. Anybody else? Okay. Some time. We have 12 answers. All right, so for you guys who give doxycycline, you got it right. Okay, that diagnosis is pretty good. You have your edema migrans right there. That's the kind of picture you'll see in your board example. Okay, so doxycycline is your treatment. You don't need to do the testing. Again, if somebody does the testing, it's most likely going to come back negative because it's kind of early. Okay, the ofloxacin has no role in all this. Testing for babesiosis, I guess you can think about, but again, doesn't really seem to have that many things suggested for babesiosis. All right, now I get a little bit more interesting now. Probably more closer to what I see patients in clinic. 65-year-old woman, 3-month history of right knee pain. No previous injury to the joint. She lives in a rural area and has experienced frequent tick bites over the last several years. Doesn't recall any tick attachments in the last 6 months, and she has had no fever. Physical exam, temperature is okay. Pressure rate a little bit elevated. Pulse rate is pretty decent. Respiratory rate seems pretty decent as well. Right knee is swollen, but without warm or erythema. Preputus is present with passive flexion and extension. Patient has no skin lesions. Arthrocentesis is performed, and synovial fluid analysis is compatible with inflammatory arthritis. On laboratory testing, result of Lyme antibody screen is positive. Western blot IgM are positive. Western blot IgG is negative. So again, 3-month history of right knee pain, no fevers, okay. Tick bites, maybe. Not a lot of symptoms otherwise, not a lot of fevers, okay. Again, that should refresh automatically. Let me know. So what should we do? Okay. 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 Right. Oh, that's interesting. Okay. Ooh. Right. It's very interesting. Okay. I have to say, just for disclosure, actually, those are questions from the Mix-Up 17, actually. I have to take the boards this year. But, so those are supposedly questions well made. I have no role in those questions, though. Okay. That makes sense. But that's my disclosure. Those are the kinds of questions you might see on your board exam. So it's not me picking on you at all. Okay? But this one was more popular. I guess it's because it's a little bit more confusing, I guess. And actually, let's start with, I guess the right answer for that is that no additional evaluation is required. Okay? And I guess the trick part is that the IgM was persistently positive after the symptoms. And again, that's more likely to be a false positive test. It's a test that is telling you that it could be reacting, but it's definitely not Lyme disease. So you don't need to do any testing. You don't need to do a PCR to detect Lyme disease on that synovial fluid. And because of that, you don't need to give any antibiotics. You might need to work with your rheumatologist in trying to figure out what else might be causing inflammatory arthritis. But I can tell you that it's not Lyme disease. All right. Last one. 36-year-old man, fatigued for 1 year, intermittent headaches, sore throat, joint and muscle pain, no difficulties falling asleep, and gets the hours of interrupted sleep, but non-restorative sleep. He has seen several physicians over the past year. CBC with differential have been obtained, thyroid testing, glucose levels, which were normal, and again, tested, again negative. Somebody did an HIV test, negative. He's been in a monogamous, heterosexual relationship, no history of blood transfusion or IV drug use. Otherwise, the history pretty remarkable. Family history, depression, diabetes, takes no medications, he's anxious, vitals, remainder of the physical exam is pretty good. Evaluation for sleep disorders is normal. Screening depression testing is negative. I guess my personal comment, I really envy this guy having 10 hours of sleep. Okay. So, what should we do? Which of the following is the most appropriate diagnostic test to perform next? So, there are a lot of problems, right? Okay. Okay. All right, I think we should have a reaction to it. It's been pretty consistent in general, I guess. Okay. So let's just start with the question, with the options. I guess that's probably a very important teaching. So Epstein-Barr virus infection. That's a very classic question, and sometimes we see that in clinic for referral. Last one I have was last month, actually. A person coming with that needed to be seen because she had a positive test for Epstein-Barr virus, and she's been having that for years, and she's been having fatigue for years, and they've been checking her Epstein-Barr virus on a regular basis, and they wanted me to see her. I say, okay, what kind of test? So all that time they were doing an Epstein-Barr virus IgG test. That was it. Which should tell us that at some point she was exposed to Epstein-Barr virus infection, her and probably 40–50% of all people in this country. Okay? So Epstein-Barr virus was considered, I guess, or still is for some people, a cause of chronic fatigue syndrome, which is what I think this guy has, most likely. And the data to support that is zero. No. So when somebody comes telling you that it's because my Epstein-Barr is acting up, look elsewhere. It's not Epstein-Barr virus. And it's just different viruses out there. You're going to see different things shown as a potential cause of chronic fatigue syndrome, nothing like that. The HIV testing, I think, was unnecessary, so that was a good catch. I guess we didn't see a lot of risk factors, anything that looked like acute retroviral syndrome, and things like that. He got a kind of recent test, so pretty good though. All right, some people decided to just, let's check it for Lyme disease. We're talking about tick-borne illnesses in any case, and he's having all these funky symptoms. Actually, yeah, there you go. Change. That's his link. Okay. So no, this is a person that needs reassurance, not necessarily Lyme disease test. It's probably hard. I mean, this is a question. It's obviously not real life, but I think this person what we need is mostly reassurance. Right? I mean, it's a person that maybe you want to see it in follow-up. Maybe they have some changes on their symptoms, though. But to be honest, there wasn't much of anything. And he didn't really have a lot of things that are classically associated with Lyme disease. So and again, I'm pretty sure you're going to see this in your clinic. You have seen this in your clinic where say, well, this could be Lyme disease. My cousin has it, or something. That's very classic. So again, reassurance. Okay. What was the last pop singer that had it? I guess Avril Lavigne or I don't know, somebody. There's always somebody in the news on Instagram. Okay, so again, it's a very daunting task. Obviously, you're not going to get every single thing there is to know for on tick-borne illnesses, but I think you got some of the gist of the matter. So again, it's complicated. I mean, it's just, there's no way around it. There are different bugs out there, different organisms, different vectors, and obviously they move. We're changing the environment changes us. So and they have different clinical presentations and very, very subtle clinical presentations. So it's difficult sometimes to do the diagnosis. And again, as long as you understand that the most common ones in Wisconsin are anaplasmosis, Lyme disease, and babesiosis, I think you'll be in a pretty good starting point to start discerning what we need to do. But again, they're not the only ones. We didn't talk much about Powassan viruses, which the case is an arbovirus infection, so you can think very similar to West Nile virus, very similar presentation. Most of the time nothing happens. Some people get bad neurological stuff, the end. I don't have any treatment. Easy. Or you can have ehrlichiosis, which by practical purposes very similar to anaplasmosis. You treat it equally with doxycycline, so you're covered as well. So not that complicated. And again, the most important part is you think about it, you have a clinical presentation that sounds like a tick-borne illnesses. Don't feel bad to just put them on doxycycline. Some of those tests are not going to come back positive, so don't hold treatment if you have a very strong case from a clinical standpoint. Doxycycline is your best friend. And again, have a backup plan if maybe patients don't do that well in taking doxycycline, then again, don't think it's maybe resistant, but think about maybe it's another organism, which is not that common though, but some co-infection, something to think about. All right. So I'm going to leave this open just for people who might be shy in opening and raising their hands, so they can send that anonymously, just in case. But if you guys happen to have any questions, I'll be more than happy to. Yes?
Human granulocytic ehrlichiosis, is that the old term for anaplasma?
Right. Right, so 2001, around that time. And then the other one, which was human monocytic ehrlichiosis, which is what we see now with the leakage appendices, muris or muris-like. So again, it's basically a different kind of white blood cell that get attacked. Anaplasmosis and ehrlichiosis, that's simple enough for me, so I'm happy with that. And I think they're very similar, actually, they do this kind of genetic studies on the organisms, and they're very similar from a genetic standpoint. I think that's why they present very similar, they have very similar clinical presentations. So that's fortunate, I guess, we don't have to think that much, I guess, in treating those things. Any other questions?
Would you have to test for both of them?
The tests are different, right? But most of the times they come in a panel so that you will get the answer for anaplasma and ehrlichiosis. But that's the kind.
Two cases of ehrlichiosis in the last year.
Right.
And I had to specifically put that down.
Right. So that's the kind of thing that you need to talk to the laboratory and say, hey, I'm having this situation. What kind of tests you have available? Maybe it's a send out. Maybe they're going to run it in your place. But yeah, generally speaking, they have a panel in places where ehrlichiosis is much more common. They have a panel that will test leakage appendices, muris, and they will do an anaplasma as well. So again, that's the kind of thing that we want to touch base with them. Anybody else? I can see any shy souls, I guess, just in case. Probably not. Let's see. Okay, I have one, I guess. Okay. Is the antibiotic treatment different for late diagnosis, Lyme disease, duration, and effectiveness? So again, late diagnosis will imply that most patients will have more side effects, again, carditis, arthritis, and neurological stuff is what happens. And the treatment, generally speaking, will be 14 to 28 days. Again, in this country, many people will end up being treated with ceftriaxone. You go to Europe, most people will end up treated with doxycycline as a first run, and many times that's what you need. But in this country, by far, patients will end up receiving ceftriaxone. Tops will be 4 weeks. All right, well, I hope it was helpful. Again, a lot of information out there, good information. So I hope that gives you some good information to share with your patients. Okay?